Hi, everyone. This is Paul Sarajo from Minneapolis, and I'd like to welcome you to tonight's webinar from Cardiovascular Innovations, and this is on Transcatheter Mitral Innovations. This is a CME sponsored, accredited conference with the learning objectives as described here. And you're welcome to claim credit for CME starting today, going into 1 year from now with Category 1 credit available. I have the pleasure of introducing our faculty here. Our session will be moderated by Dr. Jason Rogers, with faculty Dr. Ricciardi, Dr. Serlip, Dr. Kigwe, and Dr. Yadav. We look forward to an amazing interactive discussion. I'd like to thank our sponsors, Boston Scientific, Medtronic, and Philips, for helping make this session possible. And here is where you can claim your CME credit if you should choose to do so. And then as a matter of forecasting, our next webinar will be on Wednesday, March 3rd, and the topic will be evolution of massive and submassive PE treatment. And again, sponsored graciously by Boston Scientific as well as NRE. So with that, I'd like to turn it over to the moderator for this evening, Dr. Jason Rogers.
Thank you, Paul, and welcome everyone to this webinar on transcatheter mitral therapies. We have 4 fascinating cases that will be presented by our speakers, and then we'll have time for discussion between the cases. And I would like to introduce our first speaker, Mark Ricciardi, to tell us about an interesting mitral case. Mark.
Super. Thank you, Jason, and thanks very much to the CVI Innovations Group for inviting me and for putting on these great webinars. So unless I hear otherwise, I'm going to assume that this is projecting pretty well and you can hear me. So I want to talk just a little bit about maximizing MR reduction in the current era with current generation devices, and talk a little bit about advanced techniques, but also some basic tenets of how we repair these valves. It's an 81-year-old. She got dyspnea and fatigue. She had an echo showing severe eccentric MR and a transesophageal echo showing a posterior prolapse with flail on the lateral side of P2 scallop. Here are images. Pretty obvious what's going on here in this 4-chamber views with some flail of the posterior leaflet. With some color on this in a long axis, you can see the eccentricity as you might expect with the posterior flail, and the bicon views showing that this is pretty much in the 2s, maybe on the lateral side of the 2s. This 3D, I think, confirms what we saw in the 2D. You can see the pathology there on the left, pretty obvious pathology, and then the jet looks like it's just coming off just lateral to the 2s. Hopefully this doesn't seem like I'm tracking perfectly, but you can see there's a flail width there of about 15 millimeters, and on the right hand side that's supposed to show a minimal trivial gradient. So here's the summary: flail gap of 4, flail width of 15, minimal transmitral gradient, plenty of LA height as you saw on the 4 chambers. I'm welcoming anybody who wants to interject at any time, since I'm sure whatever you guys have to say would be more interesting than what I have to say, but this seems like a pretty straightforward edge-to-edge repair case.
Well, you're setting us up for something.
No.
Anytime somebody says something straightforward,
And Anane knows this. That word straightforward is banned.
Never.
Yeah, that and the word chip shot.
The exit door for anybody is to say the word straightforward.
Yeah. No,
So,
I got to tell you.
Anane, what clip would you choose here?
Yeah.
Sorry, let me move that a little bit. So if I remember correctly, basically this was a P3 flail, if I remember correctly from the images. And I don't remember what the gradient was here. The gradient was about 1. So going out towards the lateral commissures with that much with that little gradient, that much regurgitation, I think that it's safe enough to say that I would first go in with an NTW right now, and then see what results that I have with that. And I have enough room to add something else if I need to. But I'd rather choose the smaller clip if I'm going out towards the commissures, and with the wider clips, I anticipate that I should be able to get satisfactory mitral regurgitation reduction with just a single clip, hopefully.
Yeah, I would agree. A wide clip. It's sort of more central, so I'm not sure it's really
Or I can't really. I need to get out of the way.
lateral P2, but I agree. A wide clip, and probably you could use either NT or XT. There's enough leaflet length. Mark, why don't you keep going?
Yeah. So exactly, X2W, sure. It's easy, it's big and fat. We have a lot of leaflet length. We got a pretty wide jet. And I think if we were to go back a couple 3 years, we might even say, let's plan on an XT or a clip over the pathology, and maybe even stabilize it with a second device. To make sure that we don't have an SLDA, and make sure we have a good durable result so that we can promise our patients good long-term success. So here's the procedure, and there is no big surprise here, so everybody can relax. So here's real time. This is pretty easy. Nice trajectory. We're on top of that valve. On the right-hand side of your screen, you can see a decent grasp there. Would you guys agree?
Yeah, and I really want to commend the imaging here, which shows the shaft, the clip, the leaflets all at the same time. I mean, this is not always something I think achievable, but this is really the optimal imaging. So yeah, I agree. This is outstanding example.
I mean, you see the gripper bouncing and the posterior leaflet, very reassuring.
Yes.
Exactly. Love it.
And the leaflet is not curled or anything like that.
Yeah, right. And I know maybe even some people on this panel have talked about measuring your leaflets and pre and post closure and get a sense for how much is actually tucked in there. But we thought we had quite a bit of leaflet on both the anterior and posterior. So what do you think of this result here on the left? You can see there's clearly some residual MR on the right. We've, quote, split the jet.
Yes.
Anybody sort of take this and go home?
Are you fully tightened here?
On the right-hand side, yes.
Yeah, Molly, what do you think?
I think you could get a little bit more leaflet. I think we would probably try to optimize and grab a little bit more leaflet.
And
this is a good one,
okay,
because
awesome.
this is what I struggle with. So the outflow of the MR jet is a splay, but the PISA is small. And so you know, we can get big splays with small EROs.
Yes,
and
absolutely.
What do you do? Because and the dilemma here is when you see these splays, you know what the echo tomorrow is going to read on the transthoracic. It's not going to be kind. Exactly. Yeah, and so do you optimize the splay? Do you optimize the PISA? You know, and I struggle with that. I would love to hear what you guys would want to do here.
You know, I think that just comes with experience with it. You're absolutely right, but even, you know, depending on who's reading that transthoracic echo, I don't think it's not a chip shot to even be able to read what truly is mild or moderate MR, you know, because you're right, you get this big splay, but it doesn't necessarily mean that that's a lot of MR. It's just high velocity through a small, you know, orifice.
Right.
It still looks like, though, that you could get, I mean, I think we would probably try to get a little bit more leaflet in that. And, you know, with, I guess, with this system, this was a G4 system, you said?
Yeah.
Then you could, you know, just open up one side, grab a little bit more leaflet.
That's I think, a very reasonable approach. The problem is with degenerative MR, it never gets better over time. So whatever you leave now can come back to bite you. So, you know, something, I think probably this is not in 2021, probably not acceptable, quote unquote acceptable. I mean, it's a good clinical result, but if it's not the best result you could get. So Mark, what'd you do?
Yeah, I think those are just perfect points. So here we go. So, okay, this is our thinking. Let's reposition this. Let's grab a little more PML. Thank you, Molly. And maybe isolate the MR to the lateral side of the clip so we can set ourselves up for a second clip. We often talk about stabilizing the first clip with the second one, certainly in the early generation devices where you maybe have a couple NTs here. So that's what we did. We agreed with everything you said. So here we are with the second grasp now. It looks like we do have a little more posterior leaflet. And on the right-hand side, you can see that we're definitely not as lateral as we were before. Arguably, maybe still getting the pathology within the device, but we're making a little room for a second device here. And so here's what we got. On the left, we got a partially closed device. And on the right, we have a fully closed device. So we've achieved what we said we were going to do. We got rid of the medial side of that splay, and then we're left with lateral. Not a ton of lateral. So what are the next steps? It's not bad. Call for next patient release. I think that's a not unreasonable option. We could stay the course. We said we were going to maximize the PML, that we're going to move a little bit medial, and we're going to make some room lateral. So stay the course, baby. Just do it. Resolve that small jet. Stabilize the first device. I think go back 2-3 years, I definitely would do that. And maybe even today, but not on this particular day. We decided to reposition and adjust the arm orientation a little bit. And this is where I wanted to just get into the basics, because I think that the G4 is so enticing. It's such a great device in so many ways. And I think, but I don't think these devices can overcome basic tenets of what so many people on this panel have taught us over the years. So here, we're going to optimize. We're going to do some independent grasping. So on the left, you can see that the posterior gripper is up and the anterior gripper is down. And on the right, they're both now down. So we didn't release the ML at all. We maximized the PML by doing just a very mild Tarzan maneuver, just going a little posterior, grabbing more PML. And this is our result.
Wow.
Nice.
So I think this isn't meant to show. I think we could have gotten this result in Paul could have gotten this result in 2013, and some of the other people here could have gotten it even just a couple 3 years ago, maybe with 2 devices. And so that's the baseline again, and this is the final. And we didn't, as expected, didn't affect the transmitral gradient at all. So. So some thoughts that already came up, and I don't want to take up any more time than I have to, because I know those other cases are great, but maybe I'll just run through what my thoughts were and anybody wants to add. So early generation devices would have sufficed, I think, for sure, to get rid of this MR. We likely would have done it with 2 devices, one to get rid of the color, as it were, and then to stabilize maybe the first. The G4 may allow for improved MR reduction, but arguably the basics become more important, not only to ensure leaflet insertion, but also to avoid stressing the leaflets, which you could probably talk all night about, with these longer arms, which I think they really can. So positioning and arm angle just as important as ever, maybe more important with these longer arms. The wider arms should not be used, in my view anyway, in place of adequate arm orientation. Just because they're fatter and they grab more doesn't mean that you don't need perfect arm orientation. And the wider arms, in conjunction with the independent leaflet grasp and the allowing you to optimize your insertion, may allow for maximum MR reduction without the need for a second, quote, stabilizing device or a second device to reduce your MR. So those are my thoughts. I'm happy to hear any others. I think you guys brought up a lot of the things that I wanted to talk about.
Actually, I think you brought up a really good point, because the longer arms, you're right, can be easier to just try to grab more leaflet. And it's really important to get that orientation. You want the coaptation line to be as close to what it's supposed to be, right? Because I think it can be easy with the longer arms and the independent grippers to really screw up the coaptation line if you're not careful, by just by moving, more posterior or whatever, or more anterior, depending. I think we all have to keep in the back of our mind what that coaptation line is, and like you said, you can and make sure that the arm orientation itself is correct to begin with.
Yeah, that was a great example, Mark. I would have wimped out and did a second clip and not repositioned the second time, but you did the right thing. I will say one word is from experience. Anyone over 80, I kind of try not to do a lot of moving around, just based on experience of fragile leaflets. And the worst thing that happens is you try to get too perfect with one clip and you end up tearing a leaflet or something. So I think we should be encouraged to reposition, but keep in mind, what inherent frailty of the leaflet and the risk of that. Somebody asked what the blood pressure was of this patient. I responded I didn't know, but that's less important with primary MR. Do you know? I mean, we don't normally drive up the blood pressure in patients with primary MR like we would with secondary, but do you know what the blood pressure was, just because we had the question?
No, and I'm not going to make up the answer.
Okay.
But certainly the patient did not have low blood pressure, and we do that. I think that we do try to do a mini stress test if the blood pressure is low, because we don't want that tomorrow's surface echo to ruin our day. So I definitely will. I want at least normal blood pressure at the end, and typically we see the blood pressure go up once you get a good grasp. So it wasn't low.
Mark, when you said that you were going to reposition, I kept going through my head, the enemy of good is better. Don't do it. But you got such a great result.
Mark is very.
You can't achieve excellence without striving for perfection, and I struggle with those two things all the time. And to be very honest with you, I don't know that I would have done it this way every time.
But I think you did. I think you did the right thing, Mark. I mean, yeah. I think we would have needed to optimize one way or the other in 2021, and you got it done, and it's beautiful.
Good.
Well, for repair MR, for the independent and the intermediate study, this is the result that we have to get.
Mandatory.
Yes. Absolutely.
Excellent. Well, Molly, you're next. So thank you, Mark. That was amazing.
Thank you.
All right.
Now you get to make comments from the peanut gallery. So
yeah,
you're part of.
Yours is way more exciting. Okay. So this is an annuloplasty ring dehiscence roll for Microclip. So this is in the early days of Microclip. So this was not with the G4, and it was with the old Microclip. All right, so this is a 68-year-old female with a history of having a 26 mitral annuloplasty ring. It was a CG future band. It was placed in 2006. She presented with increasing shortness of breath over a 6-month time period. Up until then, she was riding her 3-wheeled bike without difficulty. She had no P&D or orthopnea, but she had some chest pain. The biggest thing is that her BMI was 50, and she had hemochromatosis from chronic hepatitis, AFib, depression, hypothyroidism, and some heart failure. Her echo showed a normal or relatively normal EF, and she had this dehisced mitral annuloplasty ring that was dehisced along the posterior annulus. It was intact at the anterior annulus, and the annulus had begun to dilate, so she had severe MR. And we saw her in clinic, and given her redo, her morbid obesity, and her other comorbidities of hemochromatosis and chronic hepatitis, we felt that she was high or prohibitive risk for surgery, and therefore a candidate for Microclip.
Wow.
Oh.
Yes, so this is what it looked like. And so you can see the dehisced ring here on the posterior annulus.
it's hard not to salivate while looking at this.
Right. Very wide Pisa. This is us getting the Transeptal. And then when we went to place this, we had kind of like what you were talking about. We wanted it to be positioned exactly right. And so we had multiple kind of positioning and repositioning because we wanted to get a little bit more on the medial side of P2, because at the time, since this was just the regular clip, we figured we were going to need 2 clips if we could. So this is the leaflet capture view. And when we dropped the grippers, we had a mean gradient of 4. And we tried multiple times and couldn't get anything less for 4. And we had quite a bit of MR, but we felt that we could still place another clip right next to the first clip without getting a higher gradient. So that's what we did. So this is after we closed it and released some of the tension. So you still see that there's quite a bit of MR. It's what it looked like. And when we released it, we were a little bit worried. It wasn't moving very well. I don't like to see it having that much movement. So we wanted the second clip kind of for stabilization. So we came in just lateral to the first clip, and it was a little bit easier to place. We tried multiple different maneuvers to try to get rid of this residual lateral jet, still with a gradient of 4. After a while in there, we decided that we were going to live with that residual gradient. We didn't think that we could place another clip. The vena contracta actually, and this is what you were talking about, Paul, so it looks like it's kind of huge, but the vena contracta area was only 0.15. So after that, we decided to release it, and it really stabilized that first clip. And this was the discharge echo the next day, in very, very mild MR. We also do what you were talking about in these functional cases, elevate the blood pressure and make sure that that we have a good result. Gradient here was 6. And so at 30-day follow-up, she still only had mild MR and no shortness of breath, and never came back to our clinic after that, despite us trying to get her back in at 1 year. But she's, I actually called her to find out, and she's still doing well.
Fantastic. Comments?
That's a great case, Molly. Which clip was this? Was this the XT or the NT?
This was NT.
That's a great result with that.
These are 2 NTs.
Did you?
Biggest issue.
Sorry, go ahead, Freddie. Sorry.
I was just saying that biggest issue in these post-repair cases is oftentimes the posterior leaflet is short and resected. So a lot of times you just don't have anything to grasp. There was a little bit of leaflet there, but still very challenging. And the first thought when you showed the image, the first thought that came to my mind was, which side of the ring are you going to go drive the clip?
Yeah, we had decided from the beginning that we were going to go there on the posterior side, and it wasn't that difficult to get to. The puncture kind of helped. It needed to be fairly high, and then yeah.
Had the surgeon taken out any leaflet? Do you know, Molly?
No, so this was in 2006, and we could not get the op report. So I don't know.
I mean, whatever they took out, it must have been pretty minimal.
Yeah, it was pretty minimal. I mean, we had looked at it and looked at the TE and felt like that there was enough leaflet to be able to grab.
Yeah, and I think the other, Pradeep, you're talking about which device, but if this had been this year, I don't think any of us would have put in an XT. Either
No,
the XT is in there because of the length, right? But
Right.
even if you had put in a W, NTW, would you have allowed yourself a second device? And I don't know. I bet you guys know the data, but it seems like the least frequently used device is probably the XT now. And NTs seem to be touch-up devices, at least in my experience.
Mhm.
But here, if you had put an NTW in there, I don't know, maybe your gradient after adding an NT might have been 7 or 8. You might have had to let it go. So in some ways, this might have benefited from putting 2 narrow devices in.
Yeah,
You guys have thoughts on that?
I don't know.
Yeah.
I think we would have tried maybe an NTW.
I
if
think
we
so
had.
too, yeah.
Yeah.
Do you think it would have allowed you to put in a second device though?
Not sure we would have needed a second device.
Well, that's the other thing. Yeah.
But you're right, though. I mean, we might have been stuck, you
Mhm.
know?
Because some of the MR that you had there looked like it was coming through the clip.
Yeah.
So I wonder if a W would have taken care of that.
Hmm.
Yeah. Yeah.
I think these post-surgical cases are always fun because if you fail, they're just going to get the therapy they deserve anyway, which is replacement. So I think they're always worth trying.
Oh, definitely.
Even when there's no leaflet, you can always try, and you can be successful even when there's almost nothing there. The challenge is always, how, as Pradeep said, how much leaflet is left behind, and then also if the ring is intact, unlike yours, if there's stenosis.
Right.
Stenosis always gets in the way.
That was a nice case.
Right. And knowing what the surgeon did is often helpful. Did they resect? Are there some cords, etc.? And on some of the restrictive restrictive annuloplasties where it's a complete ring and the residual orifice is quite small, sometimes you can fit one clip in, but the approach angle is very, you need very much of an aorta hugger to engage the short posterior leaflet. So one tip would be for those cases, actually it's just clip on a stick. You basically just steer with the guide, you point the guide straight at the valve, and you can really get like a very aggressive kind of aorta hugger to grab the posterior leaflet. It can be almost impossible to use the delivery catheter sometimes. But they are fun cases. Everyone's different. And I agree with Paul. They're worth a shot because otherwise the patient's just going back to the OR. They're going to get replaced.
Sometimes, Jason, and I'd be curious to see what you think of this. Sometimes I go very posterior in the transeptal because if there's no leaflet, I'm just raking and just catching whatever is there.
Yeah.
And that's what we've done sometimes. And I've called it clipping to the annuloplasty band, but really what I'm doing is I'm just gathering any tissue that's there and just kind of holding it together, hoping it will stay.
Right.
But you can get really posterior to do that. But the aorta hugger creation, I've actually found that quite useful for some of these FMR cases, because the tenting is in that direction.
Mm-hmm.
I saw this when I was in Japan once, and I was like, "Oh, that's smart," and it actually works quite well. So it's kind of fun to create an aorta hugger.
Yeah. Hook the posterior leaflet a little better. So Molly, your patient did well and felt and never saw her again because she felt so well. So that's good.
I was a little, when I was looking at this, I was like, God, we haven't seen her in a while. So I called her.
Okay.
So I couldn't make it up. Yeah.
Yeah.
I called her and
She answered the phone. That's huge.
She actually answered the phone.
Yeah. And
No
the
caller
imaging
ID.
there was good. I mean, the ring can shadow. It was right above your grasp zone. So your imagers did a great job. I mean, there's some limited literature in using some adjunctive ice as well, but that's also the challenge with these cases. So,
Paul Grayburn makes it look really easy, but I expect it's much harder than what he shows us.
Excellent. Well, let's move to the third case. Pradeep has a case for us.
All right. Thank you very much. Thank you, Paul. Thank you, Jason, CVI. So the title is Elephant in the Room, and I guess in 5 minutes from now, you'll probably agree with me that's a reasonably suitable title. So this is a 72-year-old female with severe mitral regurgitation, dyspnea and exertion, classic symptoms, NYHA3, a lot of medical history, COPD, home oxygen, GFR 35, walks with a cane. So prohibitive risk for any kind of surgical approach. Grafts are patent. And this is a transthoracic echo. You see right off the bat some mitral annular calcification, MR, mean gradients around 7. And the CT shows circumferential heavy MAC with an annulus of around 450 to 610. And while Paul is thinking this would be a great case for Tendyne in MAC, at least at that time, a few months ago, we did not have Tendyne activated at our site. So he said, why don't we just model 29 Sapien and see how the new LVOT looks? And it's 160-ish with a septal clearance from the valve of around 3.5. So we may end up with a gradient if we choose to just do a Sapien, and it may not be life-threatening gradient, but it could be of significance. So we talked about her and we said, why don't we do Lampoon in addition to the Sapien 3 in MAC? So this is procedural day. On the table, TEE, no surprises, heavy MAC with MR. So we set up with our retrograde or the classic Lampoon, in which you see 2 guides coming from the aorta. One is in the LVOT through which Astado and the piggyback are, and then the second guide is on a run-through rail, which has a snare in the left atrium. And then we electrify the Astado, pierce the anterior leaflet, snare the wire, make that flying V, advance it, and position it on the anterior mitral leaflet. In 2 orthogonal views, you can see LAO, caudal, RAO, the flying V's position. And now you can also see a temporary balloon tip, temporary pacemaker has been placed via the left femoral vein. So then we cross the valve with an Agilis, pigtail, put a Safari in, do a septostomy, and bring the valve in. And this is why we personally like retrograde Lampoon rather than antegrade, because it simply allows you to just have your valve ready to go as soon as you lacerate the leaflets. So everything going per the plan, going really smooth. You pull the flying V up, lacerate the leaflet, and then go ahead and deploy the valve. Real nice smooth inflation. We're very coaxial to the annular plane. You see the nice calcium, little forward push. Good inflation. This was 4 cc's extra volume. And then the valve height looks pretty good. There's some posterior PVL. We still have a wire across. But then let's, while the echo guys are looking at the PVL, we are looking at the fluoro screen like, wait a minute, what's happening to the pacer lead here? That seems to be interacting as the balloon's going up. So let's just try to pull the pacer in. So as you pull the pacemaker back, it's literally stuck. It's not moving. Moves a little bit, and the radio opaque part is back, but gets stuck between the annular calcium and the Sapien. So while me and my co-interventionalist is discussing what kind of snare or bovie are we going to use to cut this pacer, our esteemed surgeon is like, let me just do a tug test on the valve. How secure is this? And the pacer fortunately rips right where the radio opaque marker is. It just comes out, and the radio opaque part was relatively secure nicely in that posterior gap. It was still post-dilated.
Can you just explain how
Sure.
how did the pacer? I mean, most people think of the pacer in the RV. So how did this? Are you
So
get to that?
I think what happened was there was a PFO, and even the balloon was up as we advanced. It was just a very, very coincidence, and we had not done septostomy. So even with the balloon up, it just crossed through the PFO and went right through the mitral valve in the LV. Just luck of chance or bad luck. If you wanted to do it
Wow.
again, you won't be able to do it. And we didn't realize, in retrospect, you see it all the time, that you could see there is little tenting of the pacemaker. But that was all retrospect. You know, there's lampoon happening, so many things happening. We're so focused on the critical thing and forgot about this minor pacemaker.
Wow, that's pretty. Just I love doing these webinars because you see stuff you just never really think of, and this is a great example.
Oh,
So pacemaker through the PFO into the LV
Into
during
the
a TMBR.
And you know,
Wow.
the EKG, when you're pacing, it looks funny.
yeah.
But the point
Yeah.
is that you're so focused in lampoon and placing the valve in MAC right that you want to land the valve right. You're like, it's not even in the back of your mind that pacer could have crossed. So
Wow.
we still are left with PVL, and we said, well, this PVL is not bad. It's not going to cause heart failure, but then hemolysis often is an issue in these valve and MACs. So while we are here, let's just put a plug in. So AVP 12 in, great result, completely eliminated any sort of MR, no LVOT gradient. Mean mitral gradient was around 1.1. So I think lesson is just sometimes minor steps also become important in these complex procedures. Nice.
That is good.
The last phrase is the best take-home message I've seen in months.
Absolutely. They're going to be the one fixing it, right? They'll yell at you less if they do it.
Pradeep, was that Vino?
I'm not going to say it. But you know.
Can you show that where it broke off again, Pradeep?
Yeah. Can you go back and let?
Sure, yeah. So it is the valve redeployment. So you can see it, it's interacting very, and now it's so obvious, like how can you miss this?
Yeah. Wow.
And then I'll show you next slide.
Well, you can totally miss that because you're not like, I mean, that is so not what you're looking at, you know?
Yeah. But, you know, all these slides, like you go back and you see every place, like even here, you can see right below the valve, it's stenting. Why is it doing that? And here also, when we bring the
that's the best view there, Pradeep.
Yeah.
That LAO view. Can you go back to the LAO view?
Yeah.
I think it's this one.
Yeah, right one.
This one right there.
That is it.
Yep.
Yep.
See it.
Yep.
And the EKG was classic. When we went back and look at it, like, guys, look at the pacing. So, but it's all retrospect. Just because you're looking at all these piggybacks and flying V's, and it just got distracted.
Did you, when you go back and look at your films, was it only when the valve was across that, you don't think it was the valve that pushed it through your?
No, it was not, because we see it even now. If you pick, like, you know, before the valve, we're doing a septostomy and it's already across. And it happened after we had harpooned the leaflet, we made our flying V, and then we said, okay, this is a quiet time, let's just put a pacer in.
I think the only way you could have topped it is if you put the pacer through the flying V.
Well, I have done that where Safari went through the flying V, but that time we caught it, like, you know.
Yeah. Phenomenal.
Wow.
Hey, Pradeep, I'd like to massage your case for a little bit more here on the LVOT issue. Could you go back to that?
Sure.
I think a lot of the people watching this webinar and all of us, every time we see a case like this, you know, we confront this LVOT issue. So maybe you could just point out again, you said it was 3.5 millimeters, but
sure.
there are some interesting features on that maybe Paul is our expert with Tendyne and MAC.
On this, you want to see the CT?
Yeah, the CT.
Okay. No, I'm going to
I
go
would
back.
love for
Sorry
Paul
about
to
that.
give us a few words on, sort of things he looks at with anterior mitral leaflet length. And
today we would have definitely at least put this patient through the Tendyne scanner, but at least at that time we didn't have Tendyne. But Paul, here are your comments.
But I think there's a good chance this patient, even with Tendyne, would not have qualified, and principally because if you look at that anterior leaflet, that's probably a couple centimeters, maybe more.
24 millimeters.
Yeah, and it's not restricted at all, and plus you have a septal bump there, and you did the right thing with the lampoon, and I think this patient likely would have been disqualified from current Tendyne studies. It's just my feeling. You never know until you put it through, but just based on that anterior leaflet length and the orientation, I suspect that would have been the case.
What's your take on early versus mid versus peak systole for these measurements? That's a topic of debate.
Yeah, I mean, I the paper said it very well. We need to be looking at probably early more than late, and at the very least, at least the average, and not paying attention to just the smallest. It's about, who cares what the valve position is at the end of systole, right?
Right.
It's at where it is during the early and mid part of systole was where it's important. And so I do think we need to be more rigorous about that. And I must admit, I don't think we have been hardly at all. I think we are just worried about causing harm so much that we look at what the smallest is and assume that the smallest diameter reflects the entire cycle, which really hasn't been the case.
did you have any LVOT gradient at all at the end of your case?
Not at all.
That's amazing, right?
And that's why we chose to do it, just because the anterior leaflet's not at all calcified. And even though we had all these pacer issues, this was relatively like 90-minute case, not more than that. So we thought, it's always at the end, there's nothing you can do about it. Maybe an alcohol ablation if the septal's right. So why not be proactive?
She had coronary disease, probably would have been hard.
Very hard to do.
But Pradeep, can you go to the positioning of the sapien? This is where I get flummoxed. In the fluoro view, when you're deploying the valve. I mean, talk to us about how you position this, because you look at that marker. You end up a little on the LV side.
Right. So there are two ways. Some people you'll see they'll do a LV gram to just define the annulus. Our planning is mostly CT based, and as the balloon starts inflating, it almost always wants to push atrial. So as the balloon goes up, see it pushed atrial. So you pause there for a second and let your first operator push in, pull the wire back, just so that your skirt is landing right at the MAC. And that becomes a little more critical in these MAC cases, just to seal those gaps.
Yeah, because if you go 2 LV, then you'll get leaker on the skirt.
Right, exactly. So
if you go 2 HO, you'll get leaker on the skirt that way.
Absolutely.
So it's a real expert maneuver you're showing here.
Right. And fortunately, in this case, the skirt knee LVOT was pretty good. So we knew that you could afford to go 90-10 if you had to.
Yeah.
So we do measure skirt knee LVOT on everybody.
Incredible case.
Very good case, Pradeep.
Any other comments?
What are you going to do about that little remnant of a pacemaker lead? I presume just how would you manage this? Anticoagulation for life, or?
I mean, this is, Paul, you're lacerating the clips and putting Tendynes in, so it's a nice, secure posterior place. We were actually joking, like, should we have inflated, when the pacer was intact and we had PVL, should we inflate the balloon of the pacemaker? The PVL would go away.
I was thinking that too. I thought that would have been awesome.
Yeah,
I was just gonna ask.
At some point, you'll have to cut that pacemaker out, so balloon would come down. But the leak was right where the pacer was.
So did you have any problems navigating your delivery catheter around it to put the plug in?
No, not at all.
So it was a pretty good hole then.
Yeah, it was very good hole. Yeah,
Yeah.
so it was a glide wire, 8 French sheath, and AVP2.
Oh, wow. All right.
And how did you follow? Just CT, or did you bring him back for a fluoro to make sure the
You know,
TP is
we
still there?
did not even fluoro and no CT, just an echo at 30 days. And she was clinically doing very well. If she was a little more young and robust, maybe we would have done a CT. But part of me didn't want to look at the CT and see where this went.
Well, these cases are why they invented protonics. So I commend you for this. And just take your PPI and you're going to be fine. But this gives me stress. But man, what a great result. Congratulations.
Thank you.
So maybe we should move on to our last case. Anene, you've been patiently waiting, and usually this is where, we will say the fellow's looking for a job, fellowship, 6 months. She would like to work in Boca Raton, Florida.
Okay. Fortunately, not today.
Okay.
He's got a great job.
Okay. So
She's, that position at UC Davis. What was that?
he's coming to take my job. Excellent.
Recently vacated.
Okay. Thank you everyone for coming to this webinar, and thanks to the organizers for having me. I'm going to be talking about what complementary therapies there are for Microclip failure when this happens, and I have no disclosures. This is a case that I was fortunate to be part of as a fellow about a bit less than a year ago. So this is a 74-year-old gentleman who had undergone Microclip repair, functional mitral regurgitation, ischemic cardiomyopathy. Ejection fraction was approximately 30-35% reported at the time. When he had the clip, he was noted the next day to have SLDA, and this was stabilized by the operators with 2 clips on either side. However, for the next 4 months, he continues to struggle with NYHA class 3 to 4 symptoms due to severe mitral regurgitation. At the time, his mean gradient was approximately 7 millimeters of mercury at a heart rate of approximately 80 beats per minute at the time. And on the right screen, we see that he has a dilated right ventricle. However, even though he has an ICD across there, his tricuspid regurgitation is approximately mild to moderate on that screen. So this is his TEE that again demonstrates that the middle clip has, there's an SLD of that middle clip with severe mitral regurgitation on the top right screen, and the bottom, both bottom 3D screens, we clearly see that the middle clip is detached from the posterior leaflet with significant mitral regurgitation. At this time, his mean gradient was approximately 9 millimeters of mercury at a heart rate of about 72. So his STS risk score was estimated at about 5. He had severe COPD. He was evaluated by the surgeons, deemed to have a high operative mortality risk for mitral valve interventions, and by the heart failure team deemed to not be a candidate for advanced heart failure therapies. And so at this point, he was then considered for a procedure that was a part of a compassionate use protocol. This was based off of experience that was initially done. I think the first in man was done in 2019 in Minneapolis before I got there. But essentially what this entails is using the same electrosurgical techniques that Dr. Yadav had described to lacerate the anterior tissue bridge. And what this does is it changes the multiple orifice of the mitral valve into a single orifice that then allows them subsequent therapies. So for this, we essentially cannulate both the medial and lateral orifices, and this is done through 2 transeptal punctures with steerable Agilis catheters. We create a loop through those orifices, and then after that, that is exchanged with what Dr. Yadav was describing with the wire with the flying V. And in this view, what we have done is we then approximate that flank with the cutting edge of it to that anterior mitral leaflet bridge, to the anterior tissue bridge of the mitral valve. When we do this for this procedures, we actually have the the tendine sheath, that 4 French tendine sheath across. And so far in my in the procedures that I was fortunate to participate in, this was very helpful in that it limited the risk of hemodynamic compromise from this patient, because that device ended up acting as a spacer. Some other people have, in their experience, had to use intra-aortic balloon pumps for hemodynamic stability at this time. Now, in the middle screen, we do see that after the clip was cut, the middle one that had an SLDA actually embolized into the left atrium. And that was not entirely unexpected, because we knew it was detached from the posterior leaflet. But I guess this is one of those cases where it's better to be lucky than good, because we were fortunate that it went right back into where we needed it to be, which was towards the posterior lateral wall of the left ventricle, and stayed there. So immediately after this is changed to a single orifice, because the sheath is already in place, we can then quickly deploy the valve, which was done in the left screen, orienting the valve to the correct anatomic position, with the highest point being towards A2. And then the valve is then deployed, as we can see on the right screen. So this, at the end of the deployment, the patient had a gradient of about 3 millimeters of mercury. There was no significant LVOT gradient, which was predicted from the previous, from the pre-procedural CTs. And this unfast view, we see that the clips are located on the posterior lateral wall, and the detached one stayed there. Fortunately, on subsequent follow-up chest x-rays and CT scans, the clip stayed there. And from my understanding, the patient is still doing well 1 year later. Thank you.
So wait a second. So you embolize this thing, which of course, yeah, I'm sure you thought, okay, it's tethered to the anteriors. You got rid of the anterior. It's going to fly somewhere, but it ends up back where you sort of wanted it to be. Come on.
That is correct. Like I said,
this is Photoshop. This is like a TikTok going on here.
The Minneapolis miracle.
That's a mini. Wow, that's crazy.
How many now, Paul? How many of these cases have you done now at Minneapolis?
We've had 3. We've had 3, and I believe Emory has done 4 or 5.
5.
Yeah,
I think 5. They've published the 5 that they did.
Yep. And then there's been one other case at UAB, Mustafa's done, but that was 2 SLDAs. He didn't have to cut any. He just put a tendine inside them. So it's been an emerging experience. I'd love to hear, like, Molly, are you guys considering this for other TMVR platforms? Because, you know, I think this is part of the future. I think these clips, for the ones that fail, we need to have ways of getting rid of them.
Yeah, no, I agree. I can honestly tell you that the platform that we use, no, we haven't even, I'm not sure it would even, compassionate use would even be able to do it, at least not right now.
So the cases that you know about, Paul or Jason, all you guys, they're always, you're always lacerating the anterior leaflet, of course, and these are always SLDAs off of the posterior leaflet, or are there variations there?
Well, it's interesting. So you actually don't have a whole lot of control over that lasso.
I would say, yeah.
We try to get it to the anterior leaflet, because then the idea is you cut anterior and things fall posterior, and things are trapped that way. Whereas if you cut posterior, it can drift into the LVOT and potentially cause obstruction or gradients.
Sure.
So I think you can generally get it to the anterior, but it's kind of like throwing a rope over a telephone pole. You know, people use it to climb up because there's a lot of friction. It's very hard once the lasso is over the leaflet to be able to move it. Pradeep, you've done a lot of lampoons. You can tell us about that, but it's just
Not easy.
hard. Yeah,
It's
once
very hard to go
okay.
where you want to go. Yeah. And
So have there been instances where the device did not go posterior? You're kind of committed
No,
at that point.
no, we've been able to get it anterior, but in this case that Anane just showed, it was actually a wet your pants moment because she didn't disclose all the details. So the details were that we cut way more anterior leaflet than we had wanted, and the patient became quite unstable, and we actually lost access and across the valve. And so we had to hurry up and let's get to church, type of giddy up, and it was quite hairy for a little while. But we eventually got things back across. But I think to her point, having the valve in place is really important because especially with multiple clip bridges, we cut 2 bridges at one time here, and by doing that, it created a lot of instability.
So is there a risk of PVL right where those clips are?
Absolutely. Yeah. So some of the cases where the clips have been left behind, they've actually had problems with PVL where the clips are. Yeah.
So do you think it's better to have a transapical platform for this, or would it matter rather than a transeptal? I'm just trying to picture everything in and ready.
Yeah.
Right.
I mean, it depends on who you ask. Most interventional cardiologists will tell you that they would prefer transeptal, and probably most surgeons would say, you're at the apex anyways, just do it from the apex. So there's a lot of debate. I mean, this is a very important bridge therapy, as Paul says, to be able to take patients who've had suboptimal results with Microclip and then offer them a new therapy. So this is something I think we're going to see more and more of. A lot of unanswered questions about patient selection and then whether or not the clips actually have to be removed. And probably in many cases they don't, but there are cases where you will develop PVL. And from a regulatory standpoint, when you leave a clip in, there's interactions with the frames of TMVR devices, all these things the FDA is going to want to know what happens over time. Fatigue can be harder to study. So the easiest, trial to do would be complete removal. So there's a lot of things that have to be worked out. And then I think, there has to be a reproducible way to do this, that someone can do it reliably and not using sort of off the shelf things. I mean, that's not going to be a sustainable procedural approach. But that's an exciting case and good result for the patient.
Yeah, it's a great case. But I think Molly might have been getting at, how you would have to have a lot of hardware across the septum if you were to do
That's
this.
what I was getting at.
Yeah.
Yeah, I would much prefer a transeptal mitral valve replacement. But in this scenario, he could have, when you're transapical, you can have the valve ready after you lacerate, but I just can't imagine having a valve already across the transeptal. I mean, there would be a lot of interaction with catheters and even being able to see. I'm not sure.
Right.
I'm sure somebody could figure out a way to do it transeptally, but
there's nothing that says you.
What now?
Oh, sorry, Mark.
No, go, Paul. I want to hear you say
no. I was just saying it could be a double transeptal. You know, one for the clip and roll device and one for the TMVR ready to cross. But you're right. All the profiles, there's a potential for interaction. As you're cutting, if you don't have the valve, if you have the valve in place already.
Yeah, it's pretty interesting.
Right. Yeah. Well, we've seen. We've seen kind of bread and butter Microclip tonight, and how we get best results. We've seen, a great post-surgical mitral case. We've seen an interesting elephant with the trapped LV wire, and now really, this important bridge therapy for the future. So, and I mean, we're just getting started in mitral. So, I think this is a fantastic demonstration of what's being done today and just what's coming down the line. We had a lot of questions and a lot of encouraging comments tonight on our chat line from people tuning in. So thank you for the comments. Paul, would you like to wrap up the
No,
session?
I think it's been great. It's great seeing you all. I think we're getting a sense that some of the live meetings are kicking off again. And for those of you who are feel safe enough to travel, we are still looking forward to trying to have some version of CVI in Austin this coming summer. And miss you all a lot. And I look forward to seeing you all again soon. And want to thank Jason and all the faculty and CVI for organizing this. And it's been great.